Our next speaker is Dr. Fernando Hess. He has medical degree from the University 9 de Julho in Brazil. Exercise and Sports Medicine specialization from the Federal University of São Paulo and the Brazilian Exercise and Sports Medicine Society. Specialized as a team physician from the American College of Sports Medicine. Doctorate and postdoctorate degrees in rehabilitation science. Team doctor for the women's Brazilian soccer team from 2013 to 2016. American Heart Association instructor and coordinator for the Department of Medicine at the University 9 de Julho of Brazil.
Hello to all, my name is Fernando Hess. I'm a physician from Brazil. I'm specialized in sports medicine, and I'm here to talk to you about physical activities as treatment for chronic diseases. First of all, I'd like to introduce myself. I used to work for national soccer team. Now I'm a coordinator at a university here in Brazil, but I also work with my patients from the exercise point of view of my expertise. So that's what we're going to talk about today. And first of all, I need to show you what a team physician or sports medicine doctor needs to be. And I also try to approach the team physician, the sports doctor, to Lou. Lou is this demigod. He's from the Celtic pantheon. He's one of the Celtic gods. And he was known for his all-around skills. So first of all, one of the stories from his lore tells that he intended to join a kingdom which had a king named Nuada. King Nuada, he inside his walls, inside his kingdom, he kept only the best ones from each of the expertise areas. And when Lou tried to talk to the guards, they told him, okay, so what do you have to offer? What do you have for us to won you here? And he said, oh, I'm pretty strong. And they said, well, we don't need anyone strong anymore. We got the strongest man on this side of Earth, so no need for you. Okay, so I'm quite wise. I'm quite intelligent. They said, okay, we got some of the most brilliant minds on Earth inside our kingdom. And, you know, our kingdom is rich. Our kingdom is prosper. And we just don't need any more people inside. He thought again. He said, oh, but I'm quite skilled. I have brilliant hands for blacksmithing, for handcrafting, for pottery, for any kind of manual skills. And once again, the guard said, oh, you got the best artisans in here. We don't need you. He thought to himself, and then he spoke to the guard again and said, okay, so as your king, if he has one and only one person which can do all these things as well or better than your expertise, your best guys, the most brilliant guys got. And he challenged each one of them, and he won each one of the challenges. So this is what we from sports medicine think. We need to be at least very good at everything. We need to control all the areas from medicine to be a good doctor. That's how I see the sports medicine nowadays. And I always try to talk to people and explain the basics for what we're going to talk today. So first of all, we're going to talk a lot about strength training. It has lots of different names. Even in English, we talk strength training, resisted training. We're going to talk about strength training, okay? In Portuguese, in German, we have different names for it. But basically, it's when you try to perform an exercise with some weight resisting to it. So I'm going to pull something to make some strength, to try to gain strength. And that's what we do nowadays at gyms, okay? Aerobic training is kind of easier for us to know, but is with less flexing components and more long, or we're going to talk about volume, bigger volume in the training, okay? And usually running or cycling or swimming has more aerobic component. And what we need to know, or we need to remember, that there are most of the exercises, they have both components, more of one or more of another. Okay. Well, another thing we're going to talk about today is about moderate physical activity. What does it mean? Moderate physical activity is something we understand that has the heart rate between 60 and 80% of the maximum heart rate for that person. So sometimes we need to measure the max heart rate for each one of us, but there's a simple kind of calculation we can do. It's not the best option, okay, but since we're going to talk about it now, let's try. For males, 220 minus your age, and for women we try 225 minus your age, okay, and that's supposed to be kind of your maximum heart rate, okay. So if we get 60 to 80% of that, that's moderate physical activity. And the last thing we're going to talk about, like most of the time today, is about maximum repetitions. What is a maximum repetition? Let's think about chest press. I'm going to do some chest press and I'm going to put 100 kilograms and do one repetition. Okay, I did it. Let's go for the second one. Okay, I was able to do a second one. That means 100 is not my maximum repetition. So I put a little more, 110. I do one. Okay, I did a second one, not my maximum. Let's try once again. Get 130. Okay, did the first. Oh, and I got to fatigue in just one repetition. That means 130 for that exercise is my maximum repetition. Okay, so these are the basics we're going to talk about today. But before we get to the therapeutics or to the treatment, let's talk about this, primum non nocere. This is a phrase in Latin where what it means is, first of all, don't do any bad. Don't do any worse to your patient. So when we talk about exercise, most of the physicians nowadays, they say, oh, you got to eat better, you got to do some exercise, and you got to live well. Okay? Okay. So what is do some exercise? Which kind of exercise? How much exercise? When do I do exercise? What am I supposed to do in my exercise? And most of the physicians do not know about it. But what I'm saying is exercise is like medicine. It has prescription, it has a dose, it has a way of using it or making use of it a number of times a week, what it is supposed to do. If I intend to get stronger, if I intend to get fitter, if I intend to get treated from a condition, all of this have different prescriptions. The only thing that is common is that exercise is going to get better in every way. Your body is going to get better in every way. But as long as I don't go through an invisible wall that across this point, I'm not getting in better. Maybe I'm getting an injury. Maybe I'm stressing too much my cardio. So this is what we're going to talk about today. And the first one we're going to talk about is hypertension. It's pretty common that someone says, oh, I have hypertension, I can't train. That's not right. And the other thing is, oh, I have hypertension, I have high blood pressure, and my physician told me to do some exercises. I say, awesome, that's the way. But what did he tell you to do? Oh, I just got in the gym and now my physical therapist or my physical educator, he got me this series. Let's see. Okay, chest press, leg press, and what does it happen in these exercises? We have some blood vessels, we have arteries that can be pressed in these exercises. And when we do it, we just get more resistance and our heart has to do more, even more strength, even more power to put the blood through it. So we can get even 320 mercurial milligrams of pressure when we're doing these kind of exercises. It means that they're not supposed to be on the prescription for someone who has hypertension. The objectives of the training are clear. We intend to get lower blood pressure levels after we do some exercise. Yeah, it happens. How am I supposed to do it? What's the way? We do some moderate exercises, moderate activities, and every time I do some exercise, there's about 40 to 48 hours, which my veins, my vessels tend to be like larger, tend to be a little more, have less pressure inside them, and makes our blood pressure get to lower levels. That's awesome. Okay, doing exercise, I get 2 days, 48 hours of lower blood pressure levels. Awesome. But there are some risks, which I just told you. Careful. We can't get the pressure to make the blood vessels or arterias get pressured and have our hearts make even more strength or have higher blood pressures because of it. Okay, so we intend to prescribe, first of all, strength training, but be careful with this kind of exercises. And aerobic trainings are the best way for hypertension patients to get better. Another thing we're going to talk about is about diabetes. Well, what's the objective? First of all, I want my glycemia, I want my blood sugar to go down. Awesome. But how down? How much I want it to go down? That's what we're going to talk about today as well. First, the ways. When we do some strength training, resisted training, when I get big weights and try to lift them, I'm trying to get energy inside my muscles from another way. I'm not just using insulin to get sugar inside the muscle and make it have some strength or its function well did. I also make the GLUT4 is a protein that is in the cell membrane, which makes the sugar go inside and is activated by the insulin. But when my muscle is trying to make some strength, trying to make its function, it stimulates the AMPK way. What does it mean? I'm trying to stimulate the GLUT4 from inside the cell, not from outside, not needing the insulin. Well, that's pretty much what solves the diabetes problem. I don't need insulin, and I'm making the sugar go inside a cell and make it work. So strength training is marvelous to it, okay? But also we have some problems. What are them? First of all, high insulin levels. Why? Sometimes before training, people tend to eat something. That's correct. Because if I don't eat, especially if I have a patient with diabetes, well, they don't eat anything and they go to the gym or try some training, they can have hypoglycemia. That's not good. That makes them feel bad, even faint. But if they eat something that's really has high sugar percentage, let's say, it makes the insulin go up and then the sugar goes down and the insulin keeps up. So also I get to hypoglycemia again, okay? So careful about that. And of course, traumas, because we're talking about patients who have diabetes cause them a neuropathy. So they don't feel like their toes or extremities. It can make them have a lesion, an injury, and just have some harder time to get back and stop the training. That's what we are supposed to take care and be careful for our patients, okay? Another thing we're going to talk about is about mood disorders, especially depressive and anxious. Well, the objective, of course, is to stay well, not to be so anxious or depressive. And the best way to do it is try group activities. Okay. So, any kind of exercise, we tend to use something mixed between aerobical and strength training, but we intend to do it in groups. It preserves the sensation of being well, makes people a little more, how can I say, open to these activities, but we need to be careful of competition because these kind of patients, they do not go well with competitions. And also when we try to take out something from them, like even if we're trying to make them do their best, they don't respond accordingly. Sometimes they do not take it very well. So we need to take care with that. Be careful with this kind of patient. Another thing I intended to talk about to you is osteoporosis. It's very common that some patients have a wrong treatment for it, especially here in Brazil. Well, the objective is to make the bone stronger. Of course, awesome, seems nice, seems okay. Oh, my grandma has osteoporosis, and her physician told her to do some hydrogymnastics. Awesome. So she doesn't feel bad. But what's the way to make the bone get stronger? I need to challenge him. I need to make him get some pressure on it. Inside the water, well, doesn't seem I'm getting the pressure I needed to. So it's not the right way. We intend to get the patients to do something out of the water. We need to have some compression on the bones, okay? So, of course, we do not intend to get your grandma lifting 100 kilograms, but we intend to get her to do some slow motion movements. We intend to get her to lift some low weights, like 2 kilograms, 1/2, even 3 kilograms. That's the way. I just want her to be safe and I want her to get pressure on her bones. Another thing that we see some mistakes happening is that the bones, they were made to get pressure in an axis. Probably if I'm talking about the femur, it was supposed to get pressure from up to down, right? From gravity. If we get grandma doing like adduction, we want to try to get knee close to the knee, our femur is getting some pressure, but is the right pressure? No, we're trying to do this to him. And sometimes if a patient has osteoporosis, it can break, okay? So we intend to do just the exercise that respect what that bone was made for, what we're supposed to do, the kind of pressure we're supposed to do on that bone, okay? Another kind of patient I like talking about is the patients with acute coronary syndromes. And I'm talking about the patients who had or who don't want to have it, okay? Well, the objectives are to live well, not to have a condition, a heart condition, and of course, to live better. And the best way to do it is through ischemias. That's the point. When we see this other image I get here in my right, the left side of your notebook, of your screen, we see that some vessels are taking care of an area that were not supposed to be from them. This is a kind of collateral circulation, what we call. So if I have ischemia in one of them, another can take care of that area. So I don't have kind of a big necrosis on the heart, on the myocardium. So this is what we intend to do. Some controlled ischemias through exercise that can make my heart grow these vessels, these coronaries. This only happens to whoever trains and after lots of years of training. So young people still, even training a lot, they still don't have it. we have some years to make it improve and to make them appear, okay? And also we need to consider some risks, even for the patients who has not had any kind of heart conditions, but we need to get a set point. We can get until here. So the training charge and volume are supposed to be controlled by the physician, okay? Especially patients with prior heart conditions, we just need to get them through a rehabilitation. First of all, they do some exercise inside the hospital, then they do it with the physical therapist, then they do it with a physical educator, and just after some months, they're supposed to do it by themselves, but always keep the exercise, okay? The kind of evolution that happens with this kind of exercise, and even the years we're supposed to live well after that, they get a lot better when we respect this pattern. Another kind of patient I want to talk to you about that are really common nowadays are the patients with chronic inflammatory diseases like fibromyalgics and these kinds of patients, which are really hard to handle, but exercise proves itself very good and very efficient. So the objectives, first of all, are to make the lifestyle better. The patient have better day-to-day actions, activities, and also feel less pain. Okay, so what's the way of doing it? First of all, constant activities. I can't let this patient keep himself for more than 2 or 3 days without any physical activity. The ideal is for him to get at least once a day to the gym or with a physical therapist and do some exercises. And it's very important to practice movement in every limb, if possible, every articulation, because when we move the articulations, we get all that inflammatory cells and all that movement that can keep you from feeling that pain and that kind of situation that makes them really complaining. We're doing kind of strength training, okay? So it's kind of resisted training, but with really low repetition weight. So we do not intend to get high weights lifting. We don't want it to be strong person, just wanted to do some low weight exercises, kind of some nice lifting every day, slow and steady and nice, okay? And we have to be really patient with them because they feel pain really easily. And sometimes we don't know if they're really feeling something like an injury or if they're feeling that pain because of the diagnosis they have, okay? So we need to be really close to these patients. Is the kind of patient you can't just give the prescription, oh, do some exercise, bye, you can go home. No, you call him, you talk to him at least once a week, you talk to his physical educator, you talk to his physical therapist. We need to be close to these patients because it's really hard to get that turning point when they're not feeling well because of their disease or they're not feeling well because they have a new injury, okay? So that's the main point. And for us to conclude our conclusions for this meeting is that strength training is essential to keep body strong and also prevent injuries. So if I have a patient and he needs to come back to exercise, I always try to get him first to some strength training, make his articulations be nice and protected, his muscles be well, and we need to make possible their training sessions to be regular, to be everyday session, not to get an injury and then stop and then come back and then stop again because a new injury appears. We need it to be strong and safe. And the other conclusion Moderate physical activities may be the answer to almost everything, and they are essential for almost every patient. But the problem is they differ from one to another. My maximum heart rate and my moderate activity is different than yours, and different than my mother's, and different than my girlfriend's. And that's how it is. We need to do something specific for that patient and also calculate, if needed, how am I supposed to do a moderate physical activity for that kind of patient. Okay. Well, if you guys like this kind of subject, if you really want to learn more about it, feel free to mail me, feel free to talk to me any day. But check this site from the American Association, American Sports Medicine College. The name is exercisesmedicine.org. We can find some trainings, we can find some explanations, some good papers also. So the American College of Sports Medicine, they have this page, which helps a lot people who are interested in learning more, okay? And thank you for your time. Hope you enjoyed this. I hope it helped. And please feel free to contact me, mail me, and see you.
Oi, pessoal, tudo bem? A gente agora vai estar realizando o nosso prêmio da interação aqui do chat que tivemos. Pegamos quase todos os comentários até ali o momento que foi liberado o Forms. E agora a gente vai estar realizando o sorteio dos prêmios. Lembrando que os prêmios vão ser um livro Medcel e um livro Sanarflix, que é o APH, Manual de Assistência Pré-Hospitalar, tá bom? Então, vamos aqui começar. Oi, pessoal, tudo bem? A gente agora vai... O primeiro número sorteado foi 574.
Vamos ver quem que ganhou, gente.
Meus amigos, participaram, hein? Tem chance agora, vamos lá.
Tomara que seja eu que não tô ganhando nada.
574.
Igor, por mais que às vezes você não ganhe o prêmio, você já é vitorioso, viu? A gente te acompanhou aqui no chat, interagindo com a gente desde a quinta-feira.
A maior interação vem dele.
Foi selecionado para a próxima entrevista do Congresso, para entrar para a equipe.
E o primeiro sorteado, então, foi...
Air Fryer sem defeitos.
Igor Lana. Boa, Igor!
Boa.
Parabéns, Igor!
Show de bola.
Igor, pode entrar em contato pelo nosso Instagram que você acabou de ganhar um livro Medcel.
Boa. Vamos lá, vamos ver qual que é o próximo.
Agora o próximo.
Mais um sorteado, hein? E o número sorteado foi... Pessoal comemorando lá fora. 473.
Bora.
E o número sorteado foi... Lara Oliveira Melo, que ganhou um livro de APH do Sanarflix.
Parabéns,
Aê,
Lara, parabéns.
Entre em contato com a gente também, tá? Lá no Instagram.
Tudo pelo Instagram, gente. Não podem esquecer.
De qualquer forma, muito obrigado, viu, gente? A gente está muito feliz com a interação de vocês, com a presença. Espero que vocês estão, né, gostando aí do nosso congresso. A gente está indo para a nossa última palestra do dia e amanhã a gente ainda tem muito mais coisa boa por aí.
E amanhã tem mais surpresinhas também, hein, gente?
Isso,
Então,
amanhã a gente ainda tem muitos sorteios, pessoal. Então não percam, viu?
Bora interagir no chat, galera. E é isso aí, até daqui a pouco.
Até, gente.
Our next speaker is Rafael Curado, MD. He has medical degree from PUC Campinas, Brazil, specialized in general surgery from FAMEMA in Marília, Brazil, specialized in general surgery from the University of Campinas, Brazil, fellowship from the American College of Surgeons, master's degree in surgical physiopathology from the University of Campinas, Brazil, certification in trauma surgery from the CBC-AMB, voluntary doctor in the Brazilian Air Force, teacher in the Department of Medicine at Centro Universitário Estácio e UNAERP, preceptor for the Operative Techniques and Surgery Student Interest Group, coordinator for Surgery Clinic in pre-internship of the Department of Medicine at Estácio in Ribeirão Preto, director of the A2S course.
Can you introduce yourself before you begin, please?
Hi everyone, my name is Rafael Curado. I'm a trauma surgeon from Brazil. I've graduated from medicine school in PUC Campinas in 2008. Then I did my residency in general surgery in Marília Medical School. And after that, I came back to Campinas and finished my residency in trauma surgery at Unicamp. After that, I did my master's degrees also at Unicamp in trauma field. And it's a pleasure to be here and talk to everyone. So once again, I'm very pleased to accept your invitation, and I hope you enjoy this evening with us.
Thank you for accepting. And what is going to be the theme of your lecture?
Today, we decide to touch every one of you aborting the main pitfalls in primary access for the trauma patient, because I truly defend that every juniors doctor should know that the primary survey of a trauma patient is a main thing that everybody should know. And we are here to tell everyone what is the most common pitfalls during a primary survey.
Okay, so I can start now.
Thank you. I hope everyone enjoys. And in the end, I'll be open for any doubts you have. That's a resume from my graduation. I've already introduced myself, so I can skip this. First of all, to sum up our team for our lecture today, I would like to review some concepts with you regards to the primary accessory for a trauma patient. I believe that, especially in Brazil, most of you who will graduate from medical school will attend those patients in an emergency room, and you should know what you are going to attend in these situations, because trauma patients come from everybody, everywhere, and every time. So the airway and ventilatory management is the first step of the primary survey. After that, we should know about breathing and regards the trauma, thoracic trauma. Then we move forward to the circulation, when you should manage the bleeding of the patient and we recognize the fields of their bleeding. Then we go for the disability, when you should be aware of the traumatic brain injury or spinal cord injury. And after that, to sum up the primary survey, you should expose the patient and control the environment. I'll go through all those 5 steps telling you what really should know your pitfalls. But the first message that I want to talk to you about is about teamwork. We need to define your role as a team leader. This is a new topic from the ATLS 10th edition in 2010, when we start to look up for the doctor, for the physician who is in a position that he needs to be a leader for this team. We don't have this culture here in Brazil. Most of the times we understand that the patient will be treated simultaneously from different physicians, but we need to understand that the position of a leader should bring better results in the end. After that, we need to train ourselves in closed loop communication. We need to understand that this method is secure to minimize some errors that occurs during the primary survey. And after that, we need to understand that your performance and the performance of each professional need to be guaranteed in your role. Despite you have a huge experience in this field, you need to understand that sometimes you need to play a certain role during the teamwork for the patient get a better result. We have primary access concepts during the preparation of the patient that requires the primary assessment, resuscitation aids, and reevaluation. After that, despite the stability of the patient, you need to go further for the secondary assessment and auxiliary measures. In the end, you need to reevaluate the patient several times to define the definitive treatment. So, despite the cause of the trauma, despite of the trauma mechanism, you need to understand that we will do always this ABCDs from the trauma, from the ATLS. So now I'm gonna take a quick review from all the 5 steps so we can understand that we need to be ready for those pitfalls. And when you see a patient like that, you really start to freak out. You really start to be nervous about what should I do with this airway? How can I control it? So to protect the cervical spine during airway manipulation, it's fundamental. You need to understand that you remove the collar. Cervical collar is a step that can be done, but you need someone to help you and protect the cervical spine during every time of the primary survey. Nasal or pharyngeal cannula, we need to avoid those devices with mid-face fractures. We need to understand that some patients can't use those devices. And we need to anticipate a difficulty airway. We need to be aware that for the 5 seconds you get the first impression and first look at the patient, you need to know if this airway will be difficult or not. After that, we need to be secure of this method. When you decide to intubate a patient, you need to do the RAP sequence intubation method. And you need to understand how it's gonna be. You need to pre-oxygenate the patient. You need to do the drugs during the minutes following. And then you need to do a correct execution of the procedure. The burp maneuver and the oropharyngeal suction is very important. Sometimes you have a patient like that in the picture and you have multiple tooth fractures, a lot of blood in the oropharynx, but it doesn't can be a problem for you to decide for a definitive airway for the patient. Or for help, or consider using sublaryngeal devices is also an alternative when you're dealing with difficult airways. So the main pitfalls you have during the A of the ABCD is a hidden airway injury, especially when you are dealing with penetrative mechanism of trauma, progressive airway loss, when you decide first not to intubate the patient, and after that, you decide to review this step. When you have equipment failure because you didn't check the equipment before the patients arrive, when you fail to intubate the patient for at max 3 attempts, you need to decide when you're gonna do a critical thyroidostomy. And after that, just decide when go for a surgical airway or take a step back and decide for a supraglottic device. Talking about now for the breathing part, when we have specifically to remember the thoracic trauma, we need to understand that the failure to recognize or diagnose major life-threatening thoracic injuries during a primary survey assessment can be astonishing for the patient. Failed chest and pulmonary contusion is the primary diagnosis you need to make this at this time. Massive hemothorax or cardiac tamponage, also two major injuries that should be diagnosed clinically during the primary survey. And all those other injuries that you have when you're talking about a trauma, thoracic trauma, cervical closed lesion, aortic lesion, hemothorax, pneumothorax, and cardiac tamponage, we need to understand that if we don't do the correct diagnosis, the patient can fail during the primary survey. So the main pitfalls in thoracic trauma, it's the failure of recognize esophageal or a selective oral tube intubation, and also inadequate or technically wrong chest drainage. Those procedures, we need to train and train and train again, because those, I consider small steps during a primary survey can really bring the patient down. But when we talk about circulation, we have to understand that we need to look ourselves for three different problems. We need to look ourselves to the shock, we need to look ourselves to the abdominal trauma, and we need to look ourselves to the pelvic trauma. If you understand that you can have a problem, a major problem in those three steps, you will also anticipate any pitfalls and the patient won't go down in your hands. So when we have a patient with that, with almost 2 liters of blood loss, you need to understand that you need to get this patient some volume that will help him in this continent. You need to know how to diagnose the correct grade of shock that the patient is. So too much volume can be just as harmful as too little volume for the trauma patient. Special attention to the patient's group. We need to understand that the extreme of age, pregnancy, athletes are patients that has a different behavior during the shock. Medication is in use, and the presence of a pacemaker is also modulating how the patient will react to the shock. So we need to understand that despite we are going to continue evaluating the patient from the A to the B, to the B to the C, we need to understand when you measure the circulation, you have to understand if you are dealing or not with this patient especially. We also have to understand that the complications about the shock and the hypovolemic shock and its treatments is defined. We now talk about the lethal triad with acidosis, coagulopathy, and hypothermia, but you need to understand that medicine is evolving very fast. And now we are talking about the lethal diamond. When you start to looking at the patient with hypokalemia, that we need also to treat during the primary survey. I give you this outstanding paper published by Ditzel when he really organized the relations between acidosis, hypothermia, and coagulopathy with hypokalemia. Because we understand that the patient who has mass loss of blood is also losing calcium, and he needs to be treated as soon as possible. So we consider in this paper and the conclusions that the administration, early administration of calcium products, purulent with blood products administration has been associated with higher ionosated calcium levels and administration at the emergency department. What he's trying to say is we need to start giving calcium to the trauma patient also during the primary survey, in the primary resuscitation at the emergency department. Something that we don't have this knowledge and culture here in most trauma centers in Brazil. But also when we talk about shock, we need to consider blood pressure equal to cardiac output. You don't have to be foolish by hemoglobin and hematocrit values. You have to understand that the FAST exam, Uni-FACEF exams, negative tests do not exclude abdominal injuries. We need to understand that the patient has more physiological alterations than anatomic alterations. So we need to understand that sometimes you do an FAST exam in the patient and it's negative, but if you already look after different sites of blood loss, you have to consider that you may have the need to repeat the exam before taking a definitive care for these patients. But now, when you talk about abdominal trauma, you need to understand the differences between the trauma mechanism, if it's blunt or penetrating. And when you talk about penetrating trauma, you need to understand if it's a melee weapon wound or it's a firearm projectile. That's the main cause of the trauma, because the mechanism of trauma will give you a lot of information about how this patient can evaluate, how he can fail during your resuscitation. Also, we need to understand that combining trauma mechanisms about ejection, explosions, and etc. can be more dangerous to the patient. If you don't have the expertise to treat patients with that, you need to understand that if you're going to receive a patient who has been ejected from a car or who has been victim of an explosion, it can have more than one different mechanism of trauma, and the severity of the lesions will get higher. Also, we need to understand that facts and that compromise the physical examination as alcohol, drugs, traumatic brain injury, rib injuries, spine injuries, and pelvic traumas. If the patient has a lot of pain going simultaneously, this also can give you a major pitfall on the abdominal exam. Unnoticed abdominal injuries can be a preventable cause of death. You need to understand that despite you have a good experience on an abdominal examination, in this moment the patient is going under a lot of pain, and it will make failure to understand if the trauma is the major cause of the shock is coming from the abdomen. So when you see those different images, we have to understand when we're dealing with abdominal and pelvic trauma, you have different mechanisms. You have severe and different sites of blood loss, and it can be the major cause of death in these patients. So we need to understand that we have to go for a carefully physical examination, and also, if needed, the use of ultrasound or CT scan for the correct diagnosis. When you talk about pelvic trauma, you need also to remember that examining the pelvis excessively or repeatedly can make the injury worse. You need to understand that the ideal is that only one doctor examines the pelvis at this moment. If you have the orthopedic surgeon in your department, it should be him doing this exam. But if you are the only doctor, it's important that you have to examine and immobilize the pelvis as soon as possible. Indwelling bladder catheter is also a major risk when you have pelvic trauma. You need to understand that if your patient has an ecchymosis in the perineal, you need to understand that you can't do this procedure at this moment. So it will impact on how you're gonna evaluate the response of the patient to the shock, and do not delay the definitive treatment. If you identify that the patient is going through a grade 4 shock during the C, and you identify the abdominal, the pelvis as the main cause of the shock and the trauma, you need to understand that this patient will not respond as we expect to fluids and blood products. So as soon as possible, the patient gets the definitive care, it's better for him. So what we understand from the main pitfalls in abdominal and pelvic trauma, delaying controlling abdominal and pelvic trauma bleeding can increase the cause of death. Occult intra-abdominal heteroperitoneal lesions sometimes can be the cause of death. And back and flank injuries is also something that needs a carefully examined during the exposition of the patient. I always tell to my students during medical simulation trainings we have here that they need to go thinking like that. Oh, DA, it's okay. I have already got the airway controlled. The B is not the trauma, chest trauma is not the cause of the shock because it's only a pneumothorax. And then when you get to the C, you have the abdomen, the pelvis. And it's important for you to understand that if you don't question yourself from where my patient is bleeding, maybe the main pitfall you have during this assessment. Spinal cord and injury sensors alteration can also change the abdomen exam. Poorly placed pelvic bandage is also catastrophic because you are not stabilizing the fracture, you are not controlling the bleeding. So it will also help the patient bleed more and get further to a severe shock on an extreme position. And skin necrosis for pelvic bandage. Sometimes we tied up this so hard that it can also give skin necrosis. Remember that the patient is already in shock, so the skin is not receiving a lot of blood. So you have to understand and train for the correct position in these times. But when we talk about disability, you need to understand that you have two big pillars of lesions that we don't need to be afraid of treating and diagnosis during the primary survey. You have the traumatic brain injury, and you also have the spinal cord trauma. If you lose the fear of diagnosis and giving the patient the correct treatment during this time, you will understand that this is nothing, something that you need to be afraid. But when we talk about traumatic brain injury, you need to understand that the CCP is different than the cerebral blood flow. You need to understand that the traumatic brain injury can be a major lesion for the patient if he has a small volume of blood inside of it. If you don't have the correct Glasgow Coma Scale calculation is also a problem because we have different ways of treat the patient with different traumatic brain injury. If you are dealing with a moderate traumatic brain injury, the patient, the Glasgow between 12 and 9, it's one way to deal with him. You have to send this patient for a CT scan. You have to put the patient down in the ward. So you need to correct diagnosis the Glasgow Coma Scale. And if you fail to assess or identify neurological clinical deterioration, it will be also a major pitfall. We have a rock during the ATLX course when you talk about the obligation that you have as a physician to be continually reevaluation the patient. So despite you give the first row to the patient when you did the A, B, C, D, and E, you need also to reevaluate the patient many times as necessary. And if you delay the introduction of clinical measures in a severe traumatic brain injury, it will also be a major pitfall that you can control and do during your primary survey in an emergency department. You need to understand that you have conditions to do this, and it will at least don't cause any secondary lesions in these patients. But when we talk about spinal cord injury, you need to understand that the trauma mechanism is very important for the suspicion of the spinal cord injuries. You need to be very aware that penetrating injuries and contusion injuries associated with traumatic brain injuries, severe traumatic brain injuries, is also coming together. I like to also remind my students that we need to make some, as I say, mental flashes, memory cards, because you need to remind yourself that every patient that has a traumatic brain injury can also have a spinal cord injury. And if you don't understand this, you may have a major pitfall that can cause severe damage for the patient. Drugs, alcohol, other injuries can max the spinal cord. You can have a patient intoxicated with alcohol that are not feeling those sensitive lesions that are occurring in this moment. And at least 5% of the spinal cord injuries patients have neurological worsening during the hospital. So when you receive a patient with this kind of trauma, you need to understand that at least 5% of them will decrease, or better, increase the grade of lesion during your assist. So when you talk about neurological depth or disability during the primary survey, you need to understand that the change in the level of consciousness make it difficult to assess the spine, and remove the rigid board as soon as possible by rotating the patient in one piece. It's also a common pitfall, especially here in Brazil, because we don't have a trauma system organized here. So the patient is sometimes attending in a small hospital, level 1, level 2 hospital, and then we need to transfer the patient for a trauma center, and sometimes it takes a while, and most of the time we take too long to remove the rigid board from the patient. So we need to understand that the patient has a risk of pressure ulcer if he's unconscious, if he's paralyzed, if he's elderly, or if he's in shock, unstable. So as soon as possible, we get the possibility, we need to remove, because the board is only for transportation. And sometimes we forget about that. And almost in the end, we need to understand that exposure and environment control is the final step for your primary survey, but it doesn't mean that it's not that big deal or important. We need to understand that trauma care of a patient is driven by many people, many professionals or specialists. And at this time, we need to start organizing ourselves to understand if the patient can be treated where you are, that the patient needs to be transferred. So failure to perform the full exposure of the patient is also a main pitfall. We need to undress the patient completely. Do not perform the examination of the entire column is also a major pitfall. And if you don't suspect of back injuries, you may lose the chance for the correct diagnosis of the cause of the shock. When indicated, do not perform in bladder catheterization nasogastric tube. When you have pelvic fracture, we don't do the bladder catheterization. And when you have skull base fracture, you don't do the nasogastric tube. You can do in this time the oral gastric tube, but it's better for the patient if it's the nasogastric tube. And if you fail to control the body temperature and environment, it also can be, in my humble opinion, the major pitfall during the exposition, because it's at this time, it's the only thing that you have control. You can shut down the air conditioning, you can give the patient hot fluids, you can cover the patient. So you have to understand that you can control the body temperature, you can control the environment temperature, so you can't stop the patient going to the diamond of the trauma death. The main pitfalls at this time, it's unnoticed injuries, but it can be also recognized during the secondary survey. It will be in the second moment. We can talk about that in the future, but we have to understand that the pitfalls can be from A to E. It can occur in every time the patient is undergoing a primary survey. So if I can give you some take-home messages, I try to sum up my experience and all the knowledge that I have joining the past 10 years as a ATLS instructor and director. I will sum up with the need of specific knowledge about this team. You need to study trauma. We need to understand, and despite your professional choices, you will, in the first years of your career, attend a patient like that. So you need to understand that this knowledge is specific. It needs constant training. So if you don't attend trauma patients very frequently, you need to train yourself to be ready for these situations. It's also needs experience in this subject that will give you by time. If you have the chance to attend more and more patients, the better you get. And you need to anticipate yourself for the risk. That's the main purpose of my lecture, and the idea that I really want to pass you all, because if we don't have the chance to do everything correctly, patient will get worse during our primary survey, and people can die in our hands for some of these preventable injuries. Thank you very much. Once again, I really enjoy talking about you to trauma. It's my passion, and I'm open for all your doubts. Once again, thank you very much, and see you soon. Bye-bye.
Thank you, Dr. Rafael. It was very good, and we appreciate very much that you're here today.
Boa tarde, pessoal. A gente teve um probleminha com o Dr. Rafael, ele não conseguiu entrar, mas a gente vai mandar todas as dúvidas que foram enviadas no chat para ele e ele vai responder depois. Aí vocês podem checar o Instagram do Congresso, @iimc.medicalcongress, e seguem a gente lá também.
Então, por hoje a gente vai encerrar. Muito obrigada para quem assistiu. E amanhã as palestras vão começar às 9h20.
Até amanhã, pessoal.
Até amanhã, pessoal.
Tchau, tchau.
Tchau.
Hi everyone, my name is Lucas. I'd like to thank you for being here your third day of Congress. I'd like to thank you for the speakers for the lectures. I hope you guys enjoy the Congress. See you tomorrow.